thank you so much for having me, and thanks to the Binge and Underage Drinking Initiative for the kind invitation. It's kind of warm today, but I was telling Angelica earlier, when I came down from the San Jose area, it was a high of 93 yesterday. So this is actually a nice break for me. So as she mentioned, today for the next maybe 30, 45 minutes or so, I'm going to be talking about trends in alcohol-related liver disease in the U.S. Oops. So the objectives today will be to describe some of the trends of ALD in the U.S. We're going to talk about increasing trends in alcohol and ALD-related morbidity and mortality. And then in particular, we're going to highlight some recent data that looks at how the pandemic-related surges in alcohol really have translated into downstream complications such as cirrhosis and alcohol-related mortality. So I wanted to start off with this. This is not going to be our main focus, but I'd like to set the framework because these are some terms that you may encounter or see in the literature or in the press. So steatotic liver disease is what we formerly called fatty liver disease. So that's one key point, is the nomenclature and terms have changed, and now we call it steatotic liver disease. And the spectrum on the bottom really highlights that steatotic liver disease, or SLD, is a spectrum that involves metabolic dysfunction. So these are things like hypertension, obesity, dyslipidemia, diabetes, all the way to alcohol. And the key here is that metabolic, alcohol, and then sort of emphasizing the middle part, that there is an important interaction between two. So it helps remind us that, sure, it's important to focus on alcohol, which is today's focus, but not to forget about addressing the underlying metabolic issues that also contribute to downstream disease outcomes. And this is another way to really highlight, on the right side of the screen here, you can see the cardiometabolic factors that we think about in assessing for steatotic liver disease. And as I mentioned, these are things like body mass index, factors assessing insulin resistance or diabetes, blood pressure. Blood pressure is something that's hot in the news now, and maybe some of you have heard about the new guidelines about lower blood pressure readings for defining hypertension, and then lipid levels. Today we'll be focusing on alcohol-related liver disease, but keep in the back of your mind that as we think about the trends in alcohol-related liver disease and how to address it, that really it's important to take a comprehensive approach at addressing all of these factors if we're really going to make a difference in some of these outcomes. This slide really just sets the stage. It's sobering statistics to really highlight the dangers of alcohol. Last year, the World Health Organization estimated that there are 2.6 million deaths globally, about 5% of all deaths related to alcohol consumption. About 400 million individuals live with alcohol use disorder, and about over 200 million have alcohol dependence. In the US, the data are a little bit older, but still highlight really sobering statistics. Almost 200,000 deaths annually related to alcohol. And that's an increase. If you look at the data compared to 3-4 years before that, that's almost a 30% increase. And then something we're going to focus on a little bit more in the subsequent slides, 4,000 deaths annually among young adults less than age 21. I mean, that's really concerning and something we really need to focus on addressing, understanding how we can reverse these trends. This is one study that I want to highlight, really describe what is the prevalence, what is the burden. So this is a really nice study that looked at 3 different settings: the general population, primary care clinics, which all of us should be getting our sort of preventative care, and then those with diagnosed alcohol use disorder. And so the key points here is that in the general population, there is a lot of alcohol-related liver disease, about 3.5%. So maybe 1 out of every 25 person has alcohol-related liver disease. Many are undiagnosed, so it's a silent killer. And I think some of the things we're going to talk about in some of the subsequent slides are how we can really implement systematic ways to assess and address alcohol use disorder and alcohol-related liver disease. But the key here is if you look at the third panel, among individuals that have alcohol use disorder, look at the prevalence. 51%, so over half, have alcohol-related liver disease. Even more concerning, the black dots there, 13% have cirrhosis. So cirrhosis is sort of end-stage liver disease. So this is a stage where, for most intents and purposes, it's irreversible liver injury and liver damage. And it's something we can prevent. So part of the discussion today is really highlighting these trends and a discussion later about what programs, policies, initiatives we can implement to really prevent cirrhosis. Alcohol, so I'll just refer to it as ALD. ALD-related morbidity and mortality was rising even before the pandemic. So some of the subsequent slides I'm going to show you is highlighting data that show the rising trends in ALD and ALD-related morbidity and mortality. We're going to see that not only do you have rising rates of ALD in general, but you're going to see more advanced stage, so people that have cirrhosis, end-stage liver disease to the point where they need a liver transplant. So it's very concerning. This has led to major increases in mortality, which we're going to highlight as well. And then unfortunately, we're going to see that after the pandemic, it's really fueled surges in alcohol use, unhealthy, high-risk alcohol use. And unfortunately now, how many years are we? 4 or 5 years out? We're starting to see the downstream implications. So we're going to show you some of the complications of those surges in alcohol use that we're seeing in the clinics, unfortunately. So this is one early study that I wanted to highlight. This is a study that we used 3 different data sets. One is called NHANES, one is called Nationwide Inpatient Sample, and then a subsequent one is called the UNOS, so Transplant Database. So the first figure on the right, on your left, shows the trends over time of alcohol liver disease. And then more importantly, the bottom 2 lines in orange and blue show those with fibrosis. So those who have already developed some scarring in the liver. So scarring from chronic recurrent injury. And the point in this figure is to show that at least in the orange line here, you can see the trend increasing in the 12, 13-year period that we studied. In the figure on the right, just to orient you, this is looking at alcoholic cirrhosis-related hospitalizations. The gray bars represent total number of hospitalizations, and then the lines represent those with complications. So when we think about cirrhosis complications, we think about things like ascites, which is fluid buildup in the abdomen. People vomiting blood from liver disease-related complications. Encephalopathy, these are impaired clearance of ammonia that leads to confusion. I want to draw your attention to the solid line on the bottom, and that represents individuals with 3 or more of these complications that I mentioned. Not only are the total hospitalizations going up by the gray bars, but those with severe, multiple complications have also gone up. So again, highlighting the continued rise in patients with what we call decompensated liver disease. This is another study looking at things a little bit similarly, looking at alcoholic cirrhosis on the left, alcoholic hepatitis on the right. And what this study showed is how have the trends changed in men and women. So using 2007 as a baseline, the figure shows the proportional increase or decrease. And so what you see here is across both men and women, hospitalizations for cirrhosis and alcoholic hepatitis have increased. But interestingly, when you look at the differences by gender, you see that the rise seems to be much higher in women. And that's going to, remember that key point, because that's something that's going to be coming up again and again, is in some of the more recent data, we're seeing a sharper rise in alcohol and alcohol-related mortality in women. And then finally, this is transplant. So this is really, for the most part, end stage. So when you get to the point where you need a transplant, unfortunately, there's really two outcomes. You get a transplant or you die. So these are really things that we try to prevent as much as we can, because by the time you get to this point, there are really no options. And what we've seen here are the trends in the cause of underlying liver disease have really changed. The two lines on the top, what color is that, like teal, I guess, represents alcohol. And then the blue line right under that represents NASH, or what we call MASH now. And you see that clearly, at least through 2019, alcohol has become the leading indication for liver transplant in the US. Again, kind of aligns with a lot of the other data we're seeing with rises in alcoholic cirrhosis and decompensated liver disease. This is a very nice study, a little bit complicated, so we'll walk through it a little bit, but I think it's important because we focus a lot on the previous slides on liver disease, but this is overall alcohol-related deaths. So it's not just liver disease. We see other causes of alcohol-related deaths as well. So this is a nice study that looked at changes in alcohol-induced deaths from 2000 to 2016, stratified by gender and race ethnicity. The first figure on the left, you can see two key points. One, alcohol-related mortality, much higher in men. We know that. A lot of the data have shown that. But you see here, both men and women show very steep rises in alcohol-related mortality. Moving on to the next set of graphs, you see some differences in race ethnicity. So when you look at men, the top sort of, lighter gray area represents Latino populations. So in men, alcohol-related deaths much higher in Latino populations compared to other race ethnic groups. When you look at women, slightly different. So in women, you see that it's predominated by the blue line, which is non-Latino white. And in particular, you see this very, very steep rise. So again, it's helping us understand who are the populations most affected, and therefore kind of helps guide us on what kind of outreach and intervention efforts we need to prioritize. And then lastly, on the last panel, I think this is very interesting and important. I mean, it's so important and different that they had to put on a different panel because the scale was too high. So you probably can't see here, but these deaths are age-standardized death rates. For men, it goes up to 30. Women, it goes up to 10. But they had to separate out this group, American Indians and Alaska Natives, because it was so high, you couldn't even put it on the same graph. And you see here it goes from 20 all the way up to 140. Again, higher in men than women, but overall to emphasize that this is a very high risk and vulnerable group that continues to show high rates of alcohol-related deaths and mortality. Next figure to prepare you is going to be a little bit more confusing. Oops. So a lot of figures here, but not to confuse you, I will just highlight a few key points. What is this showing? It's breaking down by different race groups: non-Latino white, Latino, non-Latino black, Asian Pacific Islander, American Indian, Alaska Natives. And then it's also stratifying by different age groups. The two colors are showing the change. So the light color, light blue, represents 2000 to 2003. And then the darker color shows 2013 to 2016. Blue is women, orange is men. So sorry, it's confusing. There's like 3 different dimensions here you have to sort of think about. But the 2 or 3 key points are 1, higher mortality in men versus women, which we know. 2, for most groups, the highest mortality is sort of in that, I know we don't use that term anymore, but sort of in that boomer era. So those 40 to kind of late 60s. Important to think about who is experiencing some of these downstream complications. And then 3, the increase. So if you look at across most groups, when you go from the light to the dark in this area, you see that there is increase in mortality for most of these groups. This is a nice study looking at cirrhosis-related mortality. So this data looked from 1999 to 2016. They saw that during this period, cirrhosis deaths increased. But what is very important here is when they looked at the cause of death and the age of death, they found that the highest increase in cirrhosis deaths were among young adults aged 25 to 34. So AAPC represents the annual percent increase. So for every year, there was an almost 11% increase in cirrhosis-related deaths. And then when they looked at what was the cause, mostly driven by alcohol. So again, highlighting young adults, highly susceptible to alcohol-related deaths and alcohol-related cirrhosis. So then the pandemic happened. You know, we've all lived through this. It seemed like so long ago, but it was only 4 or 5 years ago. And I'm going to show you 2 studies that looked at the early, sort of the first year of the pandemic, what changes we saw. This is a very nice study published in Annals of Internal Medicine that looked at something called the Nielsen National Consumer Panel, which really looks at alcohol-related purchases. And you can see here they looked 2017, 18, 19, and then 2020. During the first, April, May, June, so the first 3 months of the pandemic, there was a 35% increase in alcohol sales, $9.5 billion. So again, highlighting these changes that we saw in behavioral patterns in the early pandemic. That's just sales. What about patterns? Similar data, they looked at the first few months of the pandemic, and they saw that overall alcohol consumption reported on a survey increased by 14%. But what's interesting is when they asked specific subgroups of population, they saw that certain people reported more increases than others. And again, we want to highlight here, women reported more increases than men. Sort of younger adults, aged 30s to 59, and then ethnic minorities. So it got cut off a little bit here, but Hispanics, this is non-Hispanic white, non-Hispanic black, Hispanics. So non-Hispanic blacks, Hispanics reported a much higher increase in alcohol consumption in the first few months of the pandemic. Increasing alcohol use during the pandemic is expected to exacerbate some of the ALD burden that we saw. And it's especially important, I want to bring us back, the reason why I brought up the first slide of steatotic liver disease is because if you have underlying steatotic liver disease, drinking alcohol on top of that is synergistic and further exacerbates the damage. Why is that important? Because some data show that probably 90 to 100 million people in the US have steatotic liver disease. So 1 in 3 have steatotic liver disease. And if you add alcohol on top of that, that's sort of a double whammy. And it further worsens the injury that you might experience from alcohol. We're going to show that pandemic-driven increases in alcohol will further increase the incidence of ALD and decompensation. We're going to see increasing, or we have seen actually, increasing hospitalizations for alcoholic hepatitis. And ACLF, we call acute on chronic liver failure. So that means someone has some underlying liver disease, you drink alcohol and you decompensate. So sudden acute decompensation. And unfortunately, we saw a lot of that in the early days of the pandemic. And then we, of course, saw a lot of people, especially in the first couple of years, requiring liver transplant evaluation related to ALD. This is a study that really brings back sort of bad memories. This is data from the first few months of the pandemic, right at the epicenter in New York City. And what they looked at were transfers to their hospital for alcohol-related, acute, severe alcohol-related hepatitis. And you can see here during that period, there was a 62% increase. I mean, we can remember the images of ambulances sort of lining up, waiting to get to the hospital in New York. And their inpatient census for liver disease as high as almost 50% were related to alcohol. So almost, and we saw the same thing. You know, I used to practice at a county hospital in Oakland, and then I moved to Palo Alto. Same thing. At Highland Hospital, at Stanford, doesn't matter where you are. In the early days, almost the entire inpatient census was alcohol related. It's very, very concerning. This is a study that uses data to sort of show some correlation. So I'll walk you a little bit through. The first panel are wait list registrations. So people sent for liver transplant evaluation for alcoholic hepatitis. The second panel are those that actually got a transplant. And then the third panel is trying to correlate that with sales of alcohol, beer, wine, and liquor. And you can see here the line demarcates March 2020. You see a sharp rise in people being referred for liver transplants, a rise in people being transplanted for alcoholic hepatitis, and it correlates very well. I mean, we see that there are complications. We know that, but these are data that really validate what we think and what we saw during those times. And this, I think, was an early study that really brings it all together and I think reminds us about the importance. This was a modeling study that looked at all these data to show we know alcohol use increased. We saw some of these data in the first few months. But what is the long-term impact of this increase in alcohol use? So they estimated that a 1 year increase in alcohol-related alcohol use because of the pandemic led to 8,000 more ALD-related deaths, almost 20,000 more decompensated cirrhosis, 1,000 more cases of HCC, which is liver cancer, and then a way to kind of measure outcomes is something called disability-adjusted life years. So additional morbidity associated with that. But that's 1 year. And unfortunately, I'm going to show you some data that shows that some of this alcohol use increase has sustained. And if we extrapolate this data, you can imagine that a sustained increase beyond 1 year can lead to a doubling, tripling of some of these sober statistics. I also practice at a VA hospital in Palo Alto, and so I think the veteran population is in some ways, a very underserved, vulnerable population. There's a lot of risk factors and psychosocial issues going on. And a lot of these individuals suffer from alcohol use disorder. And so this is a study we published recently that looked at a cohort of about 2.6 veterans in the US. And we found that about 15% overall reported high-risk alcohol use. And to put that, what does that mean? To put that in perspective, in the general adult population, it's about 6%. So it's more than double. Again, highlighting how vulnerable and high risk this population is. But when we looked at some subsets, again, even in the VA population, which is predominantly men, but there are women in the veteran population, we saw that the proportion of high-risk alcohol use in female veterans actually surpassed that of men. Almost 17% in the latest era that we looked at. Even more concerning, when we looked at young veterans, age 18 to 39, up to 27%. So 1 in 4 or more had high-risk alcohol use. So very, very vulnerable population that needs special attention to kind of think about novel ways in how we can address and offer resources to mitigate some of these trends. This is a study we published that emphasizes what we alluded to earlier. Alcohol is damaging to the liver, but it's even more damaging when you have other things going on. So if you think about your friends, your colleagues, you probably know someone that has diabetes, hypertension, high cholesterol, all of these metabolic factors. And we know that the metabolic factors contribute to steatotic liver disease or fat in the liver. And when you add alcohol on top of that, this is what the studies showed. These are in veterans, but I would say it could be extrapolated to general population. When you add alcohol on top of that, there is synergy in worsening your risk of cirrhosis. The figures here show, the dotted lines show people that increase their alcohol use, whereas the solid lines show people that maintain the same or decrease. And you can see across all figures, or actually across figure A and figure B, those that increase their alcohol use, clearly there's an increase in cirrhosis. But look at this. This is a figure sometimes I like to pull up and show my patients. If you decrease your alcohol use, your risk drops. So you can do something about it. You do have control of your outcomes. If you change and if we're able to help reduce your alcohol use, your risk of having liver disease and cirrhosis can be modified. We saw in the early days of pandemic these increases, but there are also other challenges. So we see all these trends, we see these concerning trends, but what can we do to address it? So we're going to talk a little bit about that, but first we're going to highlight the challenges. So we probably have all encountered or have family members encountered in the early days of pandemic, everything was shut down. You couldn't go in to see your doctors, you couldn't go in to get your blood tests, your imaging tests, no more in-person visits. Everything became virtual. It's good and bad. For alcohol use disorder, this is what these data showed. After onset of the pandemic, the figure on the left shows behavioral visits, so psychotherapy visits for individuals for alcohol use disorder, so behavioral interventions. The dotted line shows all visits, so you can see it dropped. It tried to recover, but it never recovered back to pre-pandemic levels. There was an increase in televisits, but not enough to really compensate for that decline. There's a lot of reasons. We can maybe discuss that during the panel, but there's a lot of reasons that probably contribute to that. Interestingly, when they look at prescription, though, for pharmacotherapy, that seemed to have maintained, and that was due to increase in availability of telehealth visits. But I would argue that both are important. You can't have one without the other. You're not just prescribing something and say, go figure it out. Prescribing pharmacotherapy is important, but it should be linked with some kind of support, some kind of psychotherapy, group intervention support, because that really enhances someone's success. If you prescribe and leave them at it, unfortunately, many will not be successful with that. And then finally, this is really getting to the data that we published recently, which looked at alcohol-associated liver disease mortality through 2022. That was the latest data they had available. And you can see here this sharp rise after onset of the pandemic. So we're seeing the downstream complications more and more. Now, 2-3 years out of the pandemic, the rise in mortality, and this is driven, you can see here on the figure on the bottom, predominantly by cirrhosis. So cirrhosis takes time. You know, you drink right now, you're not going to develop cirrhosis right away. So it takes some time, and unfortunately, that's what we're seeing now. 3, 4, 5 years out, we're starting to see the cumulative downstream complications of rises in alcohol use 3-4 years back. Stratified by men and women. Again, men, much higher mortality, but both men and women, you can see a steep rise during the early first couple years of the pandemic. Both total ALD-related mortality, and again, highlighting specifically alcoholic cirrhosis. Looking at age groups, this is very interesting. Still, the highest mortality is around the 45 to kind of 70 age. But you see here in the blue line, it's kind of small, so you may not notice it. But this blue line on the bottom represents young adults, age 25 to 84. And you see there's, again, a really sharp rise in that. And these are young adults. These are people that should not be developing cirrhosis. I mean, you should not really develop cirrhosis that quickly. But these are probably people that are binge drinking, heavy drinking, so patterns of drinking that really lead to rapid liver injury, cirrhosis, and unfortunately, alcohol liver disease-related deaths. And then by race ethnicity. So this is something we saw even in the pre-pandemic. And I think we wanted to highlight here that the same holds true in the post-pandemic period. The blue line on top represents individuals of American Indian or Alaska Native race ethnicity. And time and again, you see whether you look at overall alcohol, alcoholic hepatitis, or cirrhosis, such a stark difference. So really highlighting that this is a very vulnerable, high-risk group that is very susceptible to alcohol-related liver injury and really deserves greater attention. I mean, you probably are saying to yourself, Robert, you're saying this over and over again. We're showing the same things over and over. Well, because we're not doing anything about it. So we need to think about novel ways in how we can think of effective, novel interventions, not doing the same thing over and over, to really try and address some of these recurring trends that we see in the data. So this is something, getting to close to the end, this is something I wanted to highlight. This is a study that we're doing. It's an NIAAA sponsored study. 3 centers, so the VA in Palo Alto, the San Francisco VA, and then ZSFG is the San Francisco General, so the county hospital in San Francisco. So our aim was to try to think about how can we think of different ways to address this? I mean, we're seeing the same thing over and over, and we're doing the same thing over and over, and what do people say? You do the same thing expecting different outcomes. It's sort of silly, right? So we're trying to think of different ways in how we can maybe help better engage patients and hopefully achieve success with addressing the alcohol use. So this is we don't have data yet. It's still ongoing. So this is a randomized controlled trial where we looked at patients with liver disease. So they had underlying liver disease. They're already being seen in our clinic, and we randomized to usual care. That means just whatever we routinely do in clinic. And then something called a stepped-up care model. So if they're randomized to stepped-up care, we integrate a psychologist in our clinic, and we do 3 rounds of motivational interviewing. So every 2 weeks, they do a motivational interviewing to help understand and address what are the barriers to addressing alcohol use in their life. And then we do rapid referrals. So we in the real world, it's tricky, but this is sort of a proof of concept model. We rapidly refer, integrate, and get them plugged into addiction services, and then potentially get them pharmacotherapy. So we don't know how it'll work. I think this is a way to kind of bring the care to the patients in some way, and trying to integrate and bundle the care so that you're not, having them bounce around to different clinics. We hypothesize that that may be a better model, but we'll see. So we'll hopefully have data in this in a year or two. And then I like to show this figure when thinking about solutions. So a lot of times we focus, as clinicians, we focus on this. How do we reduce death? How do we reduce liver cancer? How do we reduce cirrhosis? But what sometimes we lose sight of is it's not that easy. And this is really highlighting the cascade of care, I like to say, that really starts from even screening, identifying individuals at risk, asking about alcohol or liver disease, and then really along the entire cascade, ensuring that people are plugged into care, getting access to resources, getting appropriate care. And it's easier said than done. I think all of us in this room have had experiences with patients or clients. It's difficult. It's challenging. There's so many conflicting barriers and challenges and distractors. But we need to remember this because it reminds us that it's complex. And we expect patients to follow our instructions and just follow up. But it's not that easy. So we need to remember this when we provide comprehensive care to our patients. And then finally, I like this figure a lot because this reminds us that, sure, again, our focus is on these downstream outcomes. But there are a lot of upstream social, socioeconomical, psychosocial determinants of health that contributes to barriers in care, healthcare disparities, and it's unique. You have to think about these for the patient in front of you. What are the barriers that he or she faces? Cultural, in their community. Maybe they're trying to juggle, I either go to my doctor's appointment or I put food on the table. So we need to think about education, stigma, understanding. So many of these factors, and it's very complex. And I think that's why I love these kinds of sessions where we have really multidisciplinary team from all aspects of care, because I think we need that for these kinds of solutions. We really need to have multidisciplinary, multi-pronged approach to really have a chance at being effective with these kind of interventions. And again, this is really just to highlight that it takes a village. It really takes all of these factors, addressing all of these factors to really be successful. Patient factors, of course, education, dissemination, insurance, oh boy, I'm not even talking about insurance, stigma. Provider factors, I think provider factors are important. We assume providers know what to do, but that's not true. We need to educate providers how to assess for alcohol, what are the warning signs, when to refer, who to refer, what are the resources. But then also we need to remember and not forget these other very important players, many of whom are in this room. Advocates, policymakers, public health departments, societies. I would say, yeah, even payers, understanding what are their aims and how can we work together to kind of streamline care. So I know in the panel we can talk a lot more about this, but just for sake of time, I'm going to move on and just say this is really just to highlight the complexity and the need for really comprehensive multidisciplinary care. So with that, hopefully I was able to summarize for you that alcohol use disorder and alcohol-related liver disease prevalence has been increasing in the US and really has been fueled by the pandemic. Hopefully I was able to show that this led to increases in cirrhosis and deaths, which unfortunately have continued to rise. we saw alarming trends in ALD-related morbidity and mortality, especially among young adults, women, and ethnic minorities, particularly Alaska Natives and American Indian populations. And the point is that we need greater awareness, better public health resources, investments, and interventions, and really a teamwork approach if we're really going to have a chance at achieving success in addressing some of these concerning trends. And with that, I just want to highlight some of the work I showed. It's not me. In fact, most of it's our team. So we have fortunate to have a lot of teams, both at Stanford and VA, as well as other collaborators across the country that we work on that are passionate about some of these issues with steatotic liver disease and alcohol-related outcomes. Great, thank you so much.
Hey, thank you. Thank you both for joining us today too, by the way. I really appreciate it. I'm going to go ahead and start with you, Dr. Wong. I have just a couple questions about your research that I wanted to ask. So you identified trends and factors associated with ALD. Could you expand on the demographic shifts you mentioned, particularly those among ALD rates among young adults and women, and what do you see as the key drivers of that change?
Yeah, great question. So just to remind everyone, when we looked at overall trends in mortality, we saw, one, differences by gender, differences by age groups, and then also differences by race, ethnicity. And so the question was by gender and age. Still, higher mortality in men. So I think that's something we need to remember. There's definitely higher mortality in men. But what we saw that was interesting is when you look at the change over time, there seemed to be a steeper rise or a more significant increase in alcohol-related mortality in women. Same with age. If you look at just the numbers, the greatest mortality were sort of in that middle age group. But the concerning trend was the changes. So in the younger age group, there was a steeper rise. So we don't know, the reasons. The challenge with these observational studies is you never really know what exactly contributes to it. So you can sort of hypothesize. Some thoughts that have been sort of raised in the literature, especially in the post-pandemic period, we saw a lot of women drinking more at home, wine especially, liquor, and we saw this reported in various different journals and studies. Not exactly sure why. The reassuring thing that maybe you have seen in the news recently is that, at least in the past year or so, there has been a peak and now a decline in alcohol use. We're sort of trying to see if that will be sustained or if this is just a blip. Young adults is challenging. I think with young adults, there's a lot of different factors. There's societal and sort of situational risk, I think. In certain settings, there may be peer pressure in drinking alcohol. You go to a party, you don't want to be the only person that doesn't drink, or if you don't drink, everyone's like, what's wrong? Are you pregnant? It's like, I just don't feel like drinking. So I think there's some, definitely societal, peer pressure, culture. The other thing that I think is contributing to this is, especially for young adults, it's no longer just wine and beer. You have all these fun drinks, these energy drinks, these power drinks that are making alcohol seem fun, cool, friendly, lots of sugar. I think that's unfortunately a lot of marketing aspects that are really driving alcohol use in young adults.
Yeah, I actually have a question on that. I'm just curious in the audience too. When we talked about alcohol use among women going up and then during the pandemic, the alcohol marketing, how many women in here remember the marketing for mommy juice? The ads for that. So I think there really was a correlation with alcohol marketing to women. Then I had a second question. When you look at your graphic here on societal structure, we're really seeing alcohol sales when you look at like sales for baby boomers and then Gen X millennials, it just keeps going down, and then Gen Z, there's the third space, sober space movement, where, and these prevention providers are all working on strategies because youth aren't drinking as much. Because of that, do you expect these mortality rates, the cirrhosis rates, to start declining with the younger population not drinking as much?
Yeah, I think that's the hope, is that we definitely see with this generation a normalization of not wanting to drink alcohol. It's okay. You don't have to drink, and I think that's a good trend that we're seeing, that there are other alternatives. And if this continues, we do hopefully will see that the trends will peak. It will take some time, because we're going to still see some people with cirrhosis that were drinking 5-10 years ago that will peak. But I think it's encouraging to see these trends, and it likely will lead to a decline if we can keep this pace.
Thank you. You highlighted a link between increased alcohol consumption during the pandemic and these ALD rates and the burden now. We're 5 years post-pandemic now. What do you see the lasting impact do you expect in liver disease trends in the next decade? Do you think they're going to continue to rise, or do you believe these rates will eventually decline?
Yeah, I think it's challenging. I think we are still going to see it rise, and hopefully it will peak soon. I think because we're seeing now complications from drinking patterns 3-4 years ago. So we're starting, others have said, we're starting to see this peak and decline in alcohol use, but really we won't see the implication of that until maybe 3-4 years. So I do suspect that this will continue to rise and peak. And we see that. We're still seeing, unfortunately, a lot of people being referred for liver transplants for indication of alcoholic cirrhosis.
Thank you. So I brought back up this slide because at IPS, the upstream prevention model is one that we use a lot. And you had it in your presentation. We wanted to ask you some questions, specifically because all of us in this room here, we focus on the same thing, preventing youth from drinking, binge drinking, and to reduce heavy alcohol use or even DUI prevention. So I have a couple questions for you, and they could be, yes or no, or however you want to answer them. But we want to know, at which point in this, which upstream factors do you believe play the significant role in prevention?
Yeah, I think there are multiple factors. I think education is key. And so I know some of the work that the people in the room here are going out, educating about dangers of alcohol, the downstream complications and consequences of alcohol, but then also providing alternatives. I think behavioral changes are important. What are the challenges? What are the barriers that are contributing to it? I think those are all important factors that we have to address, especially with younger populations.
Thank you. Can you expand on the role that healthy diets, food access, and opportunities for exercise can have on it?
Yeah, that's very challenging. I think a lot of times we tell our patients, eat healthy, as if it's such an easy task to achieve. And I think it's challenging, and there are some data showing that there are challenges with so-called food deserts. So unfortunately, a lot of these food deserts where there isn't good access to healthy foods or parks to do exercise. You tell someone, oh, exercise regularly, go to the gym. Yeah, but they don't have access to it. They can't afford it. Or they live in areas where it's not safe to go out. Or the nearest grocery store is in a different county or a different city. So I think it's a much more challenging issue to address, and I think it's sort of a bigger picture is how can we partner with groups, policy, to kind of make these more accessible. Because, it's clear, healthy diet, exercise are important. But getting to it, I think, is a different challenge that sometimes we're not really cognizant of.
Thank you. And one last question to wrap this up, and then we'll transition into Scott. Can you explain the psychosocial factors that you have listed in here in greater detail?
Yeah, psychosocial factors are important. They're multifactorial, and you can see here the point of this is really it highlights the complex interaction with a lot of these. And these go into things like having adequate support structure, having network, having resources. And that can either synergize and improve an individual's likelihood of success, or it can be a barrier. So I think the point of this slide is to really highlight that psychosocial factors together with behavioral factors, socioeconomic factors, education are keys that we need to address and really highlight for each person, because a lot of the psychosocial factors that play into challenges in access to care are individual. They may differ. Someone from this area or this population or this background may have very different psychosocial factors that they're dealing with. So one, I think, is understanding what are the specific factors, and then two, sort of thinking about how we can develop really individualized, personalized way to link these individuals to adequate resources. Because, just focusing on the downstream implications, I think, are not enough, and we've seen that because we continue to see the same trends over and over.
Thank you for that. I do have a couple more questions, but I want to go ahead and switch over to Scott because I think that he's going to help answer some of those further questions that I have later on. So Scott, thank you for joining us again. As someone who works directly with community coalitions, you have a big perspective on early intervention and further stopping disease progression and strategies for that. That's really important in this. So can you start, can you briefly share the mission of the Liver Coalition of San Diego and how your experience with the American Liver Foundation informs the work you do currently?
Thank you. Well, it's interesting. I think I'm here as a PR agent for the liver. It's the most underrepresented organ that we have. We only have one liver. We have two kidneys. And it's like your mother who works very hard and does not get her recognition. And that's our liver. Often it doesn't complain. It just does its job until it's petered out. And even then, it doesn't speak up for itself. And that's why these things are diagnosed later. And I think if we want to address long term, we have to be honest about the liver. But a lot of people don't like to talk about the liver because it's got stigma attached. In fact, even at the American Liver Foundation and Liver Coalition, we have put alcohol as the leading cause of liver transplantation on our agenda. What? It wasn't there before? Not really, because there's 100 different liver diseases. And some of them are genetic, and they impact little babies. And parents are tired of being asked if they put alcohol in the bottle. And so they want to remove themselves from any discussion about alcohol. Or they are genetic and they impact women, like primary biliary cirrhosis, who the women lobbied and got changed to cholangitis because there was so much stigma attached to alcohol. So it is real. And so this desire to remove it has been kind of brought back onto the agenda so we can have conversations with partners who are dealing with it every day. And that would be the substance use disorder counselors and addiction treatment centers and sobering centers and ER rooms. And these are relationships we don't really have, which is kind of surprising. And they don't have it with us because we're not talking about the full spectrum.
Thank you. And you let me know when you want me to shift into any of these slides during the...
I think a lot of them have been covered. It's just, I don't think we need to. I think the questions cover them.
Awesome. So what are some key factors your coalition prioritizes when it comes to preventing alcohol-related liver diseases and liver cancer?
I think what we tried to do is be a bridge builder and to bring the two sides together. So we did something with a liver specialist here in town and then an addiction specialist here in town. And we did a webinar and we brought the two sides together. And what was fascinating is that counselors didn't realize kind of this handoff that happens with their patients that are not successful with managing their addiction. And that's the treatment center. And then the treatment, the liver treatment or transplant center, we're not familiar with the amount of support available to their liver clients when they're saying, hey, if you don't deal with this, it's going to lead to this, this, and this. And they're looking for support. and they didn't know the substance use treatment community. So just kind of being this matchmaker and bringing the two sides together was amazing. And they were not, liver transplant was not aware of CalAIM, the supportive services that are wrapped around addiction or mental illness. And so these whole host of services are open to their clients that they were not familiar with. So that's one thing, just education and being kind of a PR firm for the liver and then a matchmaker.
Thank you. Now, would you agree that partnerships with community-based organizations are very important in the work that you do?
Yeah, I think they're essential. One, because the uniqueness of the two sides, they're very different. And I think when I first started with the American Liver Foundation, I was at a transplant center in New York, and the doctor on my medical advisory council said, "Hey, Scott, I think you should come up and see what a transplant center looks like." I'm like, "Okay, cool, I'll go up there. It'll be kind of fun. It'll be like a tour." Well, there were patients that, they still have wounds open because they're recovering, and the doctor's doing consults, and he's saying, "Okay, so-and-so, they need to call their family because it's not going to work for them." And, there was kind of like some oozing and stuff. And I had to go to the restroom. I almost passed out. It was very traumatic for me. And I feel like that's like in Seinfeld, yada, yada, yada. We don't talk about what it looks like with liver failure. And transplants are not a given. There's a shortage of transplants. It wasn't until recent that someone that even had any sort of history with alcohol, it's still frowned upon. And there are some protocols now where it's possible, but it's not a given. They have to demonstrate that they've had some sort of commitment in a structured program and with some sobriety under their belt. Otherwise, the center takes that highly coveted sacred organ and gives it to the next person who is also waiting for a transplant. And so, it's not a given. And I just don't think people realize that, especially young people. And Ron and I were on a call with Thelma Thiel. She's the first ED of the American Liver Foundation. I think she's 98 or something, and she, amazing woman, but she said, talk to young people about like this really cool gadget that they bought, like speakers or car radio or a new car, and then ask them, what would you feel if someone came in and started beating it with a crowbar and busting the windshield out and flattening the tires? You would be very upset. You wouldn't do it. And yet that's what we allow, we do to our bodies sometimes, either with alcohol, with injection of drugs, sharing of needles, all these things. So it really can change the perspective of young people of how we treat our body, and we treat material things so much better sometimes.
So you talked about that partnership with Ron and like other community-based organization partnerships. You have a lot of them, and I know you're familiar with a lot of the prevention regions here in this room. I was wondering how can partnerships between the community-based organizations, clinical providers, and us be strengthened to improve early detection, access to care, especially for people with substance use disorder or youth or even those underserved populations?
Yeah, I think having if someone is going into a treatment program, understanding how that program looks at the continuum of care, right? And then what their relations look like with specialty care. So do they have a relationship with the university liver or a transplant center or a liver doctor? Because your number, about 51% that are in some sort of substance use program are going to have associated liver disease. That's like a really high number. Like I just knew that we should be working with McAllister's and Turn Behavioral Health and others because we have clients that we're going to share here. Very much like diabetes and so-called fatty liver disease, but just like diabetes and fatty liver disease, we share clients. We have the same clients. The same with these treatment centers. So they should all know me, not because I used to work at Mental Systems or because I used to head up Mental Health America, because I'm with the Liver Coalition. That's why they should know me. And I can tell you that that's not how they know me.
Okay, thank you. When it comes to early intervention of the alcohol-associated liver diseases, what prevention or outreach strategies have you found most effective in identifying and supporting individuals with these early signs of liver disease?
I think talking about it is really interesting. We do a 28-day alcohol-free. thing of recovery, and it's not. People are very resistant to it because no one wants to talk about it, and no one wants. They'll join, but they don't want to promote that they're part of it. So they'll do the Mount Everest challenge. They'll run a 100-mile challenge. They will jump off a cliff challenge. But a 28-day alcohol-free challenge, although that's going to be a secret, and we're going to talk about it. And I even had a doctor that did it, and he said, I didn't want to say anything until after I did it, because I didn't know if I'd be able to finish it. Because we have alcohol at so many places in our lives. You know, we go to the beach, there's a cold beer. We go to church or communion. I mean, there's just alcohol everywhere. And even if you don't have an alcohol issue, we still drink a lot of alcohol in this country. And so 28 days free is not about saying, you're bad. It's about saying, are you aware? Are you aware of how much we drink? And the reality is, it's like when you're on a diet and you've got Snickers in your mouth, and then you're like, oh shoot, I forgot. I'm on a diet. But between you picked it up and you put it in your mouth, you forgot. It happens to you all the time. And so the 28-day free alcohol challenge, it puts it in perspective, like, wow, I did not realize, one, how much I drank, and two, how top of mind it need to be. That kind of an exercise would be amazing because it provides conversation about it. What did you learn? What was it like? Did your family participate? What was it like hanging out with people that were not participating when you were participating? It's great awareness building, and I think it all starts with just awareness, not that it's bad, because people come to their own conclusions. And after the 28-day challenge, some people go back to consuming, and other people say, hey, I like this. I'm going to go for the year. I'm going to go one more month. They'll see how they can go. And it's a very interesting conversation. So I think it starts with just awareness.
Thank you. So I remember when we were first planning this, and we were having those first initial discussions. You made a point that I was like, okay, that makes a lot of sense. You were like, hey, it's very important that we accurately identify the cause of liver, and not just associate all liver diseases with alcohol. You said that it contributes to stigma, and then also you were very big advocate. Can you further elaborate on that and why you think that's important, and how does it impact prevention and care planning when we do assume or use those assumptions or carry on stigmas?
Yeah, I did some research about stigma and chronic diseases, and there are, in some parts of the country, there are leprosy is better accepted than something to do with alcoholic liver disease. So it really, based on where you're at, people frown upon it. Attitudinal studies, if you ask, what would you feel about a teacher that had an alcoholic use disorder, or your mayor, or a firefighter, or someone that's married into your family? These are people like, oh my gosh, not my family. My neighbor down the street. I mean, it's very interesting, but the more we learn and the more we talk about it, and the more we're honest, then people get into what does recovery look like, right? And then what happens prior to addiction and what happens beforehand, so people understand that the practices and customs that we embrace today as youth will be very similar to the ones we have as young adults, which will be very similar to the ones that we have as older adults. And that will form the kinds of relationships. Just like we have a relationship with money, and we have a relationship with our faith, we have a relationship with alcohol. And how people approach that, and you can't avoid it, it's everywhere, but you can get to know it and realize, okay, this is the kind of relationship. I think that's responsible consumption.
Thank you. I have one last question for you specifically. How does your coalition use storytelling and lived experience to engage communities, opening up those dialects about alcohol, especially those who may not see themselves for being at risk of alcohol-associated liver diseases or at risk for liver cancer? How does storytelling play a role in that? And how do you guys use it?
Yeah, I think storytelling is really important, and it's sometimes difficult because once people have made it through something difficult, they don't want to talk about it anymore. But that is something with AA, the give back and lend a hand and help the next person along. I feel like we have a more open community that's willing to share their experiences, which is great. And like hepatitis C, if that's not the case, because if someone got cured from it, they're like, okay, whoosh, made it, bye, and they're gone. But with alcohol, people are more willing to kind of stick around and tell their story. And we had a young guy who came to us, like young, like out of college, had a really nice car, worked for a nonprofit, he was in some nice cars, like he had. And he was in finance, played
Especially this
baseball, like really here in Southern California. Like, wow, this guy's like really sharp. And he had his liver failed him, and he went through a clinical trial called Vital Therapies, and the makers of the dialysis machine had a thought, like you could do this for blood, you could pull the blood through, you could get the alcohol out, boost it up with a bunch of nutrients, and this person would go on their way. And although it did not get FDA approval, finally, it did help him. He swears by it, and his doctors did too. So we hired him, and nationally to work out of our office here in San Diego, and he was going to be our alcohol outreach education coordinator, very young, very energetic. And he was just kind of off. He would say, oh, I'll help with that, and then he wouldn't show up. Or he would miss appointments, or he was just not there a lot. And so I did not supervise him, but I asked him if he'd be open to having a conversation, and I said, who do you see yourself as? What kind of a man do you want to be? What kind of a worker do you want to be? Because here's what I'm seeing, and is this what your intention is? Is this how you want to show up? Because if it's not, you might want to change, because this is how I see you showing up. And then a couple weeks later, he had a big bruise, some accident, he fell. And then his mom called and said he was in the hospital and needed a liver transplant, and wanted to know if there was a 12-step that I could put him in touch with. And so we called someone that we knew, and she called her boyfriend who ran a 12-step, and he said, I'm going to code a program for codependence. So of course my desire is go help him right now. And the 12-step for AA is that's not what we do. No, we don't go save people in the hospital. When he gets out, he comes to a group, he sits in, he'll pick someone to approach, to be a sponsor, and that's how we do things. Well, he died in the hospital. That was not an option for him. And when I cleaned out his office, lots of empty bottles of vodka. I had no idea, none. Now I look back, but it is real. And I think if we don't share these stories with people, they don't understand that it's not just some organ that we don't think about. It's not just alcohol that's very glamorous. Even the colors, when they have it all lit up or backlit in the bar, a bourbon bottle is a great color. It looks good in the kitchen. It's a good housewarming gift. How could it be bad to drink it, right? These things have consequences, and I think we have to really talk about that. And if they're financial, if someone kills someone, if their liver, lots of different layers that we just don't talk about. So we can't scare them.
Yeah.
We just have an honest conversation.
Thank you. Yeah, especially when you were speaking of that individual, talking about how he was younger. You wouldn't have thought about it beforehand. That he was active, he was on playing baseball and all that. You were like, is that too heavy to talk about?
Right.
And that's when we were like, no, I think opening the conversation is what we need to talk about, because it helps reduce those stigmas. Thank you. So I want to go ahead and ask you both the same question. We're talking a lot about, barriers, access to care, stigmas, and I want to try to ask both of you guys questions that are going to focus on how research and community efforts can align to reduce the barriers, strengthen trust, and create a lasting impact. So it doesn't matter who answers first, or if you guys have an answer, if not. So with so many barriers to care, from stigma to access, what strategies have you found effective in building trust in the liver health systems, particularly in communities historically underserved or harmed?
Yeah, I think it's challenging because I think, as Scott also mentioned a little bit earlier, there's a lot of stigma associated with alcohol use. And I think one of the things that we've found helpful in trying to normalize discussions about alcohol is really being cognizant and verbalize and acknowledge that there is stigma. And there are a lot of consequences associated with alcohol use that we may not be able to understand. And sort of helping patients share their experiences and really share with us in ways that we may not be able to understand just by looking at a chart or assessing from a clinical standpoint, how is it affecting their life beyond the clinic? And I think that's one of the first ways where we can really have a honest conversation and really help us understand how it impacts them from a societal standpoint, from a whole life standpoint, and really helps us identify where they are in their sort of stages of change, and that can sort of help us better tailor, is this a time where we are ready for intervention, or is this still early in the stage where we have to talk and assess their readiness, assess their understanding? I think that's one of the key important ways that we really should approach it from a starting point.
Yeah, I think a harm reduction lens is really important. So we had, I've always kind of wanted to do like a healthy drinking page, you know. But darn, the new research won't support it because no alcohol is healthy. And so what do you do then? You can't really promote, you know, drink less, it's okay. But we can talk about harm reduction. And that is being aware of how much we're drinking. And then when you're with your friends, watch out for one another, you know? And because there's nothing wrong with alternating between a soda and a drink, or water and a drink. Or if you're outside and it's hot, you'll drink a lot more than what you thought you did. And so just raising awareness is a big thing, and then watching out for each other. If anyone's ever made hooch before, I did once. I did not drink it though because I didn't really know even what was in it. But my friend's like, oh, we'll create, we put in this bag, you stick it under your bed or something, and you leave it there for like 6 months or something. And I thought, I don't even know what the alcohol content is. Like, would it kill me? I don't know. But I didn't drink it. I knew enough not to drink it. And we just dumped it out. But it's kind of like weird stuff like that. But actually, I would be interested in knowing about the alcohol content of that. And then same with microbrewery. There's nothing wrong with learning about it because that creates knowledge and information of how much alcohol is in a spirit, how much is in a beer, how much is in wine. So I think there's nothing that's all bad. I think it's a harm reduction. Let's just learn about it so if we're going to consume, we know what we're consuming. And don't drink the hooch.
Thank you for that. If you take anything away today, let it be that. So I have one last question before we open it up to the audience for their questions. I want to act like we're in an ideal, perfect world, right? And if we're in that world, if we could invest in one high-impact community-level intervention, whether it's either policy change, education, clinical outreach, anything, what would you prioritize and why?
Well, I would say, I mean, for me on the clinical side, I think one of the challenges we've seen are lack of resources. So especially in county hospitals, you don't have access to resources. You know, addiction services, psychiatry services, mental health is way, way, way underfunded and continuing to be cut. So I think for me, that's one area where if I had sort of a magic wand, I would sort of invest in that infrastructure so that access to mental health, addiction, and resources is not a barrier. Whether people go is a different story, but they should be able to access it if they want to.
Thank you.
Yeah, and I think addiction is the one area that will push all your family away. It will push everyone that wants to help you away until you're just like broke down, and then you really need them, and hopefully they'll come back and trust that you're ready. And I think that the medication-assisted treatment, I'll just say, really is a game changer. And there are some old school thinkers that are like, nope, you got to white knuckle this, you got to go into, you got to suffer, it's like weight loss. Okay, it's not working. Can we get some help? Maybe it can reduce my weight and then manage it. And I think that's what medication-assisted treatment is. Let's help people get through, let's get some sobriety into their belt, and then help them learn about how they can manage it better. And I have a friend, who's a very close friend, who lost jobs, and but I knew when he was blacking out, when we'd go out and stuff, that was kind of his way of being. He just drank a lot, and the next day you laugh about it, and the person would say, I don't remember anything. Well, no, he really did not remember anything. But then during COVID, he lost control, and then lost housing, lost jobs, could not stop drinking. And so it was not until medication assisted treatment, which was not really being talked about in our county, it's still kind of new within the last 2 years, was not being talked about. And within some treatment programs, there's still a philosophy that you have to suffer. You got to do the work. And if you don't do the work, it'll never work. And I feel like they can complement one another. And as you said, you have to do the work. The medication alone is not going to help. It will help get you there. And then while you're sober, you can start digging deeper into why it is that you're acting the way, what's your belief system, and you kind of get those things in alignment. But I think medication-assisted treatment, acceptance that this could be a go-to, and for adolescents, it can be prescribed, and there's different medications based on different indicators. But I feel like that's a solution that is right there that no one was talking about, and I only found out indirectly. And I said to my friend, talk to this doctor about this, and he got it. I was like, oh my God. And that's what changed it. It was by accident.
Thank you. So thank you both for those thoughtful answers.